Hi, I'm David Pope from Clinical Edge. Welcome to this 14-day series on assessment of the shoulder. Throughout the 14 days, we're going to be looking at how you can work your way through systematically through the shoulder. We're going to be tying in the latest research around the shoulder to help you be really clear when you've got a shoulder patient coming in, what's going on in their shoulder and what's going to be the best way moving forward with their treatment. So that's the goal, 14 days, step by step with short videos of around 2 to 5 minutes each day and building on the material from the day before. So we're going to start with subjective history. We're going to talk about clues that people will give you in their history that'll start to guide your diagnosis. Then we're going to work our way through the objective examination. We're going to be looking at the glenohumeral joint, the scapula, the AC joint, the C-spine and thorax a little bit. And within that, we're going to be looking at different areas as well. So whether we're looking at subacromial impingement, we're looking at an instability, slap tears, AC joint injuries, or other things that are impacting, such as rotator cuff tears, those sort of things, or whether we're looking more at the cervical spine that might be causing the person's shoulder pain. So we're going to work our way through all that. It's going to be a great 14 days, and I hope you enjoy each of the parts that we've got coming up for you. And I look forward to, if you've got any thoughts as we go through, send us through in an email or pop your comments in the comments underneath. But yeah, hope you enjoy it. Hi, and welcome to day one of the shoulder assessment video series. So today we're going to be talking about subjective history, and in particular some of the patient details and the location of their pain. So some of the things that are going to guide your diagnosis are the patient's age. So you're going to be pretty aware of that already. But if the patient's likely is older, so if they're over 60 to 65, and you're tying it in with their shoulder symptoms that we'll talk about later, then you might start to suspect things like rotator cuff tears. If they're under that 60 years old, you're going to start to rule out things like rotator cuff tears a bit more. So then we want to look at the location of the patient's pain, and we really want to nail down exactly where they have their pain. So is their pain superficial, or is it a deep ache within their shoulder? So if they've got the location of their pain is more anterior and superficial, so they're talking about pain sort of over the bicipital groove, fairly anterior and superficial, then you might be starting to suspect some of the structures around the bicipital tendon, the long head of biceps tendon, and the fat pads and bursa around that. If they're describing pain more laterally, so sort of over this sort of area, you might be starting to think that there could be some subacromial impingement or involvement of the supraspinatus tendon. So really try and nail down exactly where is their pain, anterior, lateral, superficial or deep. Then we start to get into, is the pain coming from their shoulder or coming from other structures like their neck or thorax? So we want to find out, is the pain fairly local and stay just around the shoulder, or does it come from further up or below the elbow? So if they're telling you they've got some pain and it's over the shoulder, but they have a bit of pain up here in the neck or maybe down below the elbow, you might be starting to suspect that there's some cervical spine involvement. Whereas if their pain's just localised around the shoulder, then you might be starting to think that it's more of the local structures around the shoulder. They can have both. They can have cervical spine involvement and some local irritation in the shoulder, but it'll give you a good place to start with anyway and start to target your treatment, whether you're going to be starting with cervical spine or starting with their shoulder. So that's our first video on location of the patient's pain. Tomorrow we're going to be having a talk about aggravating activities, so I look forward to seeing you on day 2. Hi, and welcome back to day 2 of this shoulder assessment video series. Today we're going to be having a chat about aggravating activities that come up in the subjective. So normally you're going to ask about aggravating activities anyway, but we're going to be looking for a few things, whether in general what their aggravating activities are, so that as they go through their treatment program, you're getting a clue as to whether they're improving with different things, but also certain aggravating activities that will give you clues as to the source of their symptoms. So in general, you want to find out about overhead activities. That's not going to really help to narrow it down too much, but will give you that reassessment findings. You also want to find out, do they have a painful arc? So if they're coming up into abduction and they've got this sort of pain that gets worse through around the 90 degrees area and then gets better as they come up overhead, might give you some clues that there's potentially some subacromial impingement syndrome going on. The other things we want to know about are other activities as well. So they might mention things like had patients that are builders or bricklayers holding things out here in front of them, like a tray with concrete on it. They use to trowel stuff in. So if they're holding things up in front of them and they're getting pain over the anterior aspect of their shoulder, you might be starting to suspect that there's either some biceps tendon issues going on, or maybe even potentially the labrum, superior labrum. So that can give you some ideas. If they've got pain into extension, so say they're running and they're getting pain with running, and they tend to go into shoulder extension as they're running, or they mention that they get pain as they go into shoulder extension. If that's anterior, once again, you're starting to think they might be getting some compression of that biceps tendon in that bicipital groove, and that's going to lead you to target your treatment around that bicipital tendon, the fat pattern bursa around that area. Some of the other things that they might mention are turning their head. So they might mention, if they're looking over their shoulder to reverse, they get some pain. It's going to once again give you a bit of a clue that that's the cervical spine that might be the origin of their pain. Sometimes I even mention that as they reach out, to grab something out here and coming to more of this upper limb neural tension sort of positions, that's when they tend to get it. So you can start to go, okay, maybe there's some neural involvement, neurodynamic issues that are going to need to be addressed as well. So that's some of the aggravating activities that'll help to guide your treatment. And so we're starting to come up with the source of our symptoms, some of those aggravating activities, and starting to narrow down about some of the structures that might be involved in your patient's pain. So that was day 2. I'll look forward to seeing you on day 3. We have a bit more of a chat about objective examination. Hey, and welcome to a bonus day 2 video. This one's on irritability versus severity of pain. So it's a really important part of the history to figure out how much pain they've got. So do they have 4 out of 10, 6 or 8 out of 10? So that'll give you clues about the severity of their pain, but you're also interested in the irritability. So how quickly does it get stirred up and how long does it take to settle down? So do they get a lot of pain within hanging out 1 or 2 items on the clothesline and it takes a few hours to go away? You're going, oh, it's pretty irritable. Or does it take 3 hours of work, laying bricks, and then it settles down fairly quickly? You've got your low irritability then. So if you've got a highly irritable patient, I'll tend to avoid doing any sort of exercises on day 1. That's when I'll tend to head more into passive treatment, settling it down before we start getting into the exercises. Whereas a low irritability patient, you can go, all right, we can start to get into some exercises a bit earlier, and that'll help guide your treatment. So I hope you enjoyed our little bonus video, and I'll see you in day 3. Ask those sort of things. It'll give you some clues about what's going on and also the activities that you're going to need to modify as they go through their rehab process. Some exercises you might need to take out of their gym program or some changes you need to make to their sporting activities, maybe stroke correction, that sort of stuff. You might also ask about other things that they've been doing. Did they start a running program? They might not even connect the two, that they started running 4 months ago and they got their pain 3 months ago. So find out if there's been any sort of changes in work, trauma, or any other sort of sporting or other activity changes. So that's day 3, and look forward to talking to you more about red flags and some of the things you've got to look at for more serious pathology in day 4. Hey, and welcome to day 4 of this shoulder assessment video series. Today we're going to have a chat about red flags and keeping red flags in the back of your mind as you're going through your patient's story, just to make sure that you're ticking off that they don't have any serious pathology. So you want to ask all your general red flag questions anyway, about unexpected weight loss, your night pain, night sweats, those sort of things, any other unexplained symptoms. But you also want to ask more specific things, like do they have any pins and needles or numbness in the arm or shoulder? It might give you a clue that there's some some cervical pathology going on, or that you might need to address the cervical spine specifically. And also, if they're reporting that they've got stiffness in all directions, so in particular external rotation is restricted more than abduction, which is then restricted more than flexion, and you're starting to suspect that they do have, a potential true adhesive capsulitis or frozen shoulder, that you are then sending them off for an X-ray to make sure they don't have any humeral shaft tumours. So there's a low incidence of humeral shaft. I'll get this right. Humeral shaft tumours, but if they do have it, really important that it gets picked up. So anyone that's got any sort of adhesive capsulitis, whip them off for an X-ray. So make sure you're asking all those red flag questions, and tomorrow we're going to get stuck into objective examination. Hey, and welcome to day 5 of this shoulder assessment video series. Today we're going to have a chat about objective examination of the shoulder. And we're going to start with active and passive range of movement. So we're going to start with, you want to check your patient's active range of movement, checking for when their pain starts and if they can go any further. So they're P1 and P2. So you want to check their active range in standing for flexion, abduction, and then their internal and external rotation. Now, internal rotation in standing and neutral is pretty limited by your body. So if that's fine, you can get them behind their back and see if they've got any range of internal rotation behind their back. So you can measure all those with a goniometer, or you can use something like UberSense to measure it as well. But for ease of use, generally the goniometer is pretty good. So next, we want to check their passive range of movement. And we're not generally going to test too much of flexion and abduction with passive range of movement, but we're going to check the internal and external rotation in supine. So we're going to check that next. So to check internal rotation, you can do it either in the horizontal or frontal plane, or you can take them up into scaption, the same angle as the scapula. Generally, to standardise it, it's easy just to do it in the horizontal plane. And so you just get them into 90 degrees abduction and just allow the arm to come into internal rotation. You can then check that with a goniometer, or you can just eyeball it and check their range of movement where their resistance starts. So that R1. So the other position to check internal rotation is in 90 degrees flexion. And this tends to bias more of the posterior shoulder, but you're interested in where they feel any discomfort. So bring them into 90 degrees flexion, support the elbow, and then you can check their range of movement. Once again, don't tend to force it, just take it to get a little bit of resistance. About there, any discomfort? No. So we've got about neutral internal rotation there. What we're interested in is their range of movement, and compare that from side to side, and if they get pain anteriorly or deep in the shoulder, or more of a posterior stretch, which is okay. So to check for external rotation, you keep them in that same frontal plane with 90 degrees abduction. You place your hand on the front of the shoulder, just in case they get any apprehension or they've got any anterior laxity. It's just resting there. You allow the arm to come into external rotation while you monitor their face. Just check they haven't got they're not getting a bit worried about that position. And then if they are, bring them back, provide a little bit of a posterior glide and support them and allow it to come into external rotation. Now in her case, she actually gets a little bit of extra external rotation, and that's a way to check their external rotation range of movement. Hey, and welcome to day 6 of the shoulder assessment video series. Today we're going to have a chat about palpation. And we know from the research that palpation has terrible reliability. It's affected by a whole number of things, including the patient's sensitivity, their beliefs, and also their expectations about where it's going to hurt when you do touch around an area. So all those things are factors, but it can add something to your evaluation, I think, and it can help you to exclude some structures as well. So just to run you through some of the palpation that you can perform, and I'll show you on a model and then also on surface anatomy. So when you're palpating around the shoulder, you've got your AC joint to start with. You can palpate for any step deformities if you're suspecting any AC joint injuries. Then you can palpate down to the coracoid process, drops down to the little lump there, and from there you've got pec minor heading inferiorly and medially. Moving laterally, you've got your bicipital groove with your biceps tendon in it, and you can palpate that biceps tendon and you can flick over it. If they have pain anteriorly, but they're not tender at all on their biceps tendon, then you might start to suspect some deeper structures, like potentially the labrum or something deeper. Moving laterally, you can drop off this lateral part of the acromion onto the supraspinatus tendon, and you can palpate that tendon for any swelling or any tenderness. So we're going to also look at the humerus in the glenoid and whether that's sitting anteriorly, and it's probably best to show you that on a live person rather than on this shoulder model. But basically what we're looking for is that there's not more than 1/3 of the thickness of the humeral head sitting anterior to the acromion. So I'll show you on a live specimen now. So now we're going to work our way through palpation around the shoulder. So we can check out the AC joint, check for any deformities between the clavicle and the acromion, And when we come around the front, you'll feel just inside the humerus, there's this little lump here, which is the coracoid process. And from there, you've got pec minor heading medially and inferiorly. So you can palpate through there for any tension in pec minor. Coming laterally, you've got the bicipital groove, and you can palpate the biceps tendon over the top of that bicipital groove and check for any tenderness over that biceps tendon. Coming laterally, you can check for the supraspinatus tendon. So when you drop off the side of the acromion, you can feel that here's the supraspinatus tendon just here. You can check for any tenderness or swelling in that supraspinatus tendon. And then you also want to check for how the humerus is sitting in the glenoid. So you can palpate around the humerus, palpate on the acromion, and then you can check whether there's 1/3 or more of the humerus sitting anteriorly to the glenoid. Hey, and welcome to day 7 of the shoulder assessment video series. Today we're going to have a look at the scapula. Now, within the research, there's no clear consensus on scapular position and a relationship of scapular position to pain, which makes sense. And if you think about it, pretty much every patient that comes in has some sort of different pattern to their shoulder position that also has pain. So you're never going to have one position or two positions that are more closely related to pain. It's really independently variable depending on the patient. So what you can look at, though, is what their baseline scap position is in standing and with movement, and then you can make changes to that and see what that does to their pain. So just to run through some of the scapular positions or physiological movements that you might find in the scapula, we've got protraction and retraction of the scap. You've got internal and external rotation of the scapula. You can get elevation or depression of the scapula. You can have upward rotation and downward rotation of the scapula. And then you can have combinations of all of the above. The last one is that you can have anterior rotation of the scap with a prominent inferior angle or posterior rotation of the scap. So we've started to identify some physiological movements of the scapula, but now we're interested in what happens to the scapula, its passive range of movement, and also what it does actively as well. So first off, you need a good passive range of movement of the scapula. You need the ability of the scapula to be able to move freely on the rib cage. So oftentimes, if the scapula is not able to move freely, you can have a co-contraction of muscles around the scapula. A common pattern is co-contraction of serratus anterior and rhomboids or low traps. So then you get this almost like the scapula stuck down and it's just unable to move with this co-contraction, not unable to move smoothly. So that's the passive range of movement. I'll show you how to assess that shortly. And then we've got active range of movement. So as the person's lifting up their arm, does the scapula move smoothly and evenly with the other side? And when on the way back down, does it smoothly come back down or does it just drop back down? So when we assess passive movement of the scapula, we're looking at how well the scapula moves on the rib cage, and you can just hold onto the scapula and provide a little bit of protraction or retraction force that way, protraction and retraction. You can try up rotation and down rotation as well. And we want to compare that to the other side just to compare what the movement's like. But you can see on this right-hand side, when we wiggle our scapula, whole body moves. So not exactly ideal, not free movement of the scapula on the rib cage. When we compare this with the left side and we check out the movement, there's a lot more freedom of movement of that scapula in this resting position on the rib cage. So that easily moves without a whole body movement, and that's up rotation position's easier and down rotation and protraction. So you want to compare side to side, see which side moves the best. Which one might be a little bit restricted, then palpate around the scapula to identify which muscles might be restricting that movement. So now we want to have a look at what the scapula are doing while the person's performing an active movement. So we'll use flexion as an example of a movement that might be causing this person's pain. So I'll get you to lift your arms up into flexion, both arms at once, and you can just compare what happens with each scapula. Do they both rotate up at the same time and on the way down as well, the same amount, or what happens to that scapular control? Go again, up, yeah, and then all the way back down, slowly back down. Okay, so that's the first part of our active movement assessment of the scapula. Now we can look at performing some sort of movement assistance to the scapula to see if it changes the person's shoulder pain. So this is part of Jeremy Lewis's shoulder symptom modification procedure, and what you're looking at is supporting around the scapula and then helping to guide the scapula into different movements, one of those movements that we talked about before, so up rotation, down rotation, protraction, retraction, etc. So we're going to, if she had pain on, say, shoulder flexion, we're going to support around the scapula, so when you're ready, go again, and then help to guide that arm up into flexion and come back down and see if it changes their symptoms. If they get more range of movement or less symptoms as they're doing it, it's going to help guide your treatment towards focusing on that scapular control and in particular the direction of movement for that scapula. So you can help to guide into up rotation as they go through their movement, protraction, you can help to retract it, or you can do more of a posterior rotation tilt, any of those sort of movements that we talked about before. Experiment with those, see if you can vary the patient's pain with those scapular supporting and movements, and then focus your retraining around that. Hey, and welcome to day 8 of the shoulder assessment video series. Today we're going to have a chat about testing shoulder strength, and there's a few different ways to do it. Now, the most accurate way is with a handheld dynamometer, but if you don't happen to have a handheld dynamometer lying around the clinic, then you might need something to do some manual muscle testing. So you can use a number of different tests. There's a little bit of controversy, but the most commonly and most accurate way of testing strength itself is using a break test. So you've got a make or a break test. A make test is where the patient pushes as hard as they can, and a break test is where they push as hard as they can and then you push it to the point where they can't hold it any longer. So that's a break test. You often pick up about another 20% of strength in a break test as opposed to a make test, but if the patient's really irritable, you're probably not going to be able to perform the break test. Strength is also altered by pain. So from the research, if you've got pain when you perform a test, the test is invalid for us as a strength test. However, we still have to test their strength. So just keep that in mind. If they're getting pain, you're not getting an accurate indication of their strength. Two of the most common strength measures that you're going to perform around the shoulder are internal rotation strength and external rotation strength. Mostly you're going to perform these in neutral and standing, and Rod Whiteley's done some good studies looking at the ratios of internal rotation to external rotation strength, and ideally you want your external rotation strength to be up as close as possible to your internal rotation strength. So we're going to be looking at those ratios, and you're going to notice in particularly your swimmers that they might have really strong internal rotators from all this swimming work that they're doing, but quite weak external rotators. So that can often be a cause of or contributing factor to the person's shoulder pain. So you're going to want to address that if there is a difference in strength. So let's look at how we do internal rotation and external rotation strength testing. So just say you don't have a handheld dynamometer in your clinic, you can check the internal and external rotation strength both at once, comparing left and right, or just one side at a time. So you can support on their elbow so you don't push them over, and then you can stop me from pushing in. And because we broke their strength, that's called a break test, and then we can check that compared to internal rotation strength. Good. Yeah, excellent. Okay. So you're looking for significant differences from side to side and also between that internal and external rotation strength. So I hope you enjoyed our program from day 8. Tomorrow we're going to have a look at some special tests around the shoulder. Hey, and welcome to day 9 of the shoulder assessment video series. Today we're going to talk about special tests around the shoulder. Now, special tests are basically not valid by themselves. So, especially around the shoulder, there's a number of different issues that I'll talk you through briefly. Then we'll look at combinations of special tests that will be more useful as a combination to rule in or out different conditions. So, but to give you a bit of background, it'll help you to understand why, if you've got a positive with a special test, why that might not mean they have a certain condition. So basically, statistics are calculated on populations of people compared to a gold standard, and you're looking at getting sensitivity and specificity values. Now, those basically just the sensitivity is testing if you get a true positive, and specificity is testing if you've got a true negative. So they only compare the negatives to people that don't have the condition and positives to people that do have the condition. Getting complicated, but basically you're not getting a true indication of the overall value of a test just with sensitivity and specificity values. What you really need to do is work those into a likelihood ratio. So if you get a positive test, what is the positive likelihood that person actually has a condition? So that's your positive likelihood ratio. So if you've got a positive Hawkins-Kennedy, and then what's the chances that they actually have impingement? Then on the other hand, you've got a negative likelihood ratio. So if they test negative, what's the chances that they actually don't have that condition? And there are actually some better statistics to work with. It's something that you should be looking for values for in your studies that you read on shoulder tests or any other tests. And ideally, in your positive likelihood ratios, you're looking for 5 or greater. So the higher, the more accurate it is. And then conversely, with your negative likelihood ratios, the lower or closer to 0, the better. And then ideally, you want it around 0.2. So if you can get values close to that, if you've got a test that's got a high positive likelihood ratio, really low negative likelihood ratio, you go, here we go. This one can accurately pick up people that have it and also rule out people that don't have the test. So around the shoulder, though, there's not a lot of tests that have good positive and negative likelihood ratios. So that's the moral of the story. And the groups of patients that have been studied with these tests are not always indicative of the patients that you will see in your clinic. Might have been performed by an orthopaedic surgeon just before they're going into surgery, or they might not have blinding. They might not also be have the condition identified on MRI. So we're looking at all these things and we're going, okay, there's not a lot of great studies out there that have come up with showing that specific tests are really good at identifying specific structures. But we can use in Eric Hedges and Chad Cook's et al. Study in 2015, they have some combinations of tests that are a bit more likely to give you an indication of what's going on than others. So it's a good study, worth reading. Eric Hedges has done a couple of different studies. He did one in 2012 that was also a good one as well. So let's have a look at a few combinations of tests. I hope you enjoyed. So now we're going to check 3 different tests around the shoulder to check for subacromial impingement. The first one is the painful arc. So we're going to get the person to perform abduction and check if there's any point in range where they get more pain. So if we come up to the side with both arms or one arm, yeah, beautiful. Back down, any pain as you come. No, lovely. So as they come out, what you'll notice with the painful arc is they get through here and maybe between 75 to 120, they'll have this more painful area and it gets a little bit less towards the top. Next test we're going to perform is Hawkins-Kennedy. Most of you are probably familiar with this one, but we come into 90 degrees flexion, 10 degrees adduction, and then we add in some internal rotation, check for pain. So if we get any pain, that's a positive test for Hawkins-Kennedy. Our third test is called the external rotation or infraspinatus test. And what we're going to do is the patient's going to do resisted external rotation. So we're going to push in. I want you to stop me from pushing in. Beautiful. And we're looking for any pain with that as they're resisting that movement. So if you've got a positive in all those 3 tests, Hawkins-Kennedy, painful arc, and the external rotation / infraspinatus test, then you're more likely to have either subacromial impingement or rotator cuff tendinopathy. And as far as differentiating between those two, it's not possible with just those tests. We're going to show you one other test when we're looking at rotator cuff tendinopathy that will help you differentiate those two as well. Now, rotator cuff tendinopathy around the shoulder is pretty common, and there's some really nice ways of settling that down. So you can apply this into your assessments, and it'll help you figure out that, yes, there's a rotator cuff tendinopathy going on or not. Now, you've found out, let's imagine that Lauren has pain with shoulder flexion at, say, 120 degrees, and that's where pain kicks in. We can take her up into, we can get her in this neutral rotation position. We can resist her external rotation, so we just press fairly firmly, as long as there's no pain, not too much pain while you're doing it. Any pain there? A little bit? Less than 3 out of 10? Yeah, good. And you hold that there. 30 seconds. Good. You hold for 30 seconds. Yeah, imagine that's 30 seconds. Then relax. Repeat that 3 times. And then you get her to recheck her active range and see if there's less pain or more movement in that position. So this will give you some really nice clues that isometrics are going to be a really nice way to settle down this reactive tendinopathy initially. And as you go through your treatment program, you're going to be incorporating isometrics. When we're looking at the biceps tendon for any biceps tendinopathy, there's a couple of tests that have been found to be okay by Ben Kibler. So one of them is called the uppercut test. So, and good thing is, it pretty much fits with the movement like a boxer. So we get the patient in here, elbow flexed to 90 degrees. We bring them up here, and as they get to shoulder height, you resist that upwards movement, and you check for any pain as they do it. So if they have any pain, that's a positive for the uppercut test, positive for biceps tendinopathy. Keep in mind, it could also be the bursa that are around the biceps tendons as well. That could be one of the pain-producing structures. The other test that Ben Kibler found useful in the research for biceps tendinopathy is Speed's test. So we bring the arm up into 90 degrees flexion, we bring it across 10 degrees adduction, and then with the forearm supinated, we place downward pressure on the hand, and a positive is any pain in the shoulder over that area of biceps tendon. So push down and check for any pain. Come down. So now if we're looking at settling down what we suspect to be a biceps tendinopathy, what you can do is oftentimes they'll have pain down here with the shoulder in neutral as the long-headed biceps wraps around the front of that humerus. So if you perform any sort of biceps loading down here, it'll often be uncomfortable. So what you can do is take them out of that compressive position, and you can actually bring them up here a little bit, support under the arm up closer to 90 degrees, and then you provide resistance of elbow flexion. So hold that there. Resist that for 30 seconds and make sure that they're not doing, sometimes they want to do this uppercut thing instead of just pure elbow flexion. So, but what you're looking for is really that elbow flexion. Hold that there 30 seconds, bring it back down. 3 lots of 30 seconds to 45 seconds of resisted elbow flexion, and then come back down, recheck their range of shoulder flexion or whatever happens to be their aggravating movement. And then if you do have a biceps tendinopathy without too much of the fat pad involvement or bursatil involvement, that'll tend to settle it down really nicely, and they can use this throughout the day, every hour, or use it as a painkiller pretty frequently. So that's a nice way to identify your biceps tendon. So we're looking at a positive in Hawkins-Kennedy, the painful arc, and also the external rotation / infraspinatus test. If you get a positive in all those three, then you're likely to be able to say that it's likely to be either subacromial impingement or rotator cuff tendinopathy. Now, you can't basically differentiate between the two of those with those tests. What you can use is an isometric test of external rotation to see what effect that has on their pain and to see if it is a rotator cuff tendinopathy. So that'll help you to differentiate it. If you do that and it's still the same, you're likely to be looking at more of the subacromial impingement syndrome. So I hope you enjoyed day 9, and day 10 we're going to have a look at instability of the shoulder. Hey, and welcome to day 10 of the shoulder assessment video series. We're going to look at shoulder instability today. So there's a couple of different tests that we can use to check for shoulder instability, and shoulder instability can come in an anterior direction or a posterior direction or a multi-directional instability. So we're going to look at testing for all of these, and we're going to use 3 different tests. So the instability test that we're going to perform, first one is the load and shift test. And what we do is we support around the clavicle and the acromion. We hold onto the head of the humerus, and then we glide it forward to check the anterior stability. So we hold on here, relax your shoulder, press forward, and we check for any excess movement there. And then we glide it back. Beautiful. And both of those have got good sensitivity and specificity for instability. Our second test that we're going to perform is the sulcus sign test, where you stabilise around the clavicle and the acromion. You hold onto the arm and you create an inferior distraction of the humerus from the acromion. The third test for glenohumeral instability is the apprehension relocation test. And that's the one we performed when we were testing the external rotation, where as you go into external rotation, you keep your hand on the front of the shoulder and you check if there's any apprehension from the person, and posterior pressure on the humerus allows them to go further with less apprehension. That's another positive for instability in the shoulder. Hi, and welcome to day 11 of the shoulder assessment video series. Today we're going to have a talk about slap tears. So a slap tear is a tear of the superior labrum anterior posterior. So the labrum is in the shoulder joint, and we have attachments from the biceps tendon up through the long head of biceps, has a slip through to the superior labrum. And you can get tears around that, and they're graded into a grade 1 to 4 tear. Now, there are no tests that are really specific and sensitive and nicely go diagnose a slap tear. Now, if it's just an isolated slap tear, you've got a young patient, they've had a fall onto an outstretched hand, they come in with deep pain in the shoulder, and they've got a positive on these tests, you're going, beauty, we're looking at it, most likely a slap tear. However, if you've got maybe a slightly older patient, they might be an office worker, they might have just done something pulling a tree out of the garden on the weekend, and they've got this deep tear, deep pain, and you're not sure, you're like, is it a slap tear, is it not? You just can't know. So you might not be able to differentiate and say, they've definitely got a slap tear in this person. They might also have a bit of slap, they might have some rotator cuff tendinopathy or a bit of biceps tendinopathy or something similar. Be that as it may, you can't differentially diagnose it exactly, but what you can tell them is that the evidence says that it responds nicely to conservative treatment in general, and so you're going to trial conservative treatment. So you can't be exactly specific, but you can have good outcomes still with your treatment. So this test is called the Modified Labral Shear Test, and Chad Cook in 2012 found that it was one of the best ones for identifying slap tears. So if we come up into 120 degrees of shoulder abduction with a neutral forearm, and then we keep the patient there, check for any discomfort, and then we resist supination. So the patient supinates while we resist it, and we check for any pain. Any pain there? And that tensions the slap through that slip of the biceps tendon that goes onto that labrum. So any pain or clicking or popping is a positive for that test. Hey, and welcome to day 12 of the shoulder assessment video series. Today we're going to talk about the AC joint. Now, most commonly, AC joint injuries are traumatic. They are occasionally degenerative if you've had someone that's, say, doing a lot of bench press, that sort of stuff. But most times you're going to notice it because they've been playing footy on the weekend and they've fallen onto an outstretched hand or onto their shoulder, or maybe they've been skateboarding. Generally, it involves some sort of trauma. The most common insight is that you're going to have some sort of step deformity, and it'll range from a grade 1 with a small step all the way up to a grade 4 with complete rupture to grade 6 where you've got rupture of all the ligaments around there that require surgery. So that's what you're going to find in an AC joint injury. There's a few tests to clarify it. If you're especially down at that lower end of the spectrum, maybe grade 1, you're pretty sure it's an AC joint, but you just want to confirm, you can use these tests. The other thing you can use the tests for is, as you're going along in treatment, you can use them as a reassessment finding. So you might find with O'Brien's, for instance, that you've got pain initially, but as you go through the treatment phases, that you've got less pain with that. It's giving you a good indicator that you're making some progress. So the tests for our AC joint that we're going to use are the palpation over the AC joint, our crossover sign, and also O'Brien's. So you can check for you can palpate across that AC joint, check for tenderness around the AC joint, and feel for deformities. The second test that we're going to perform is the crossover sign. So we're going to put the hand on the other shoulder, and I'm going to get you to resist as I push towards that side and check for any pain over that acromion. The third test is O'Brien's. So we're going to bring the arm into forward flexion. We're going to internally rotate and adduct, and I'm going to press down and check for pain, any pain there, and check where that pain location is if it's over the AC joint. Remember, this tests a few different structures, so you're looking to tie together these signs to find out, is it over the AC joint, and do they have positives with those other tests as well to identify that. So I hope you enjoyed that one on the AC joint. Tomorrow we're going to look at functional activities. Hey, and welcome to day 13 of the shoulder assessment video series. Today we're going to look at functional assessment, and it's always really nice to tie in an assessment of the patient's movement or activity that they say they get pain in with their rehab. Give you really good ideas about how you're going to modify their activities and also some of the contributing factors that they've got going on while they're performing their movements. So we're going to look at running, swimming, weight training, and also boxing. They're our four main ones that we're going to look at today. So looking at runners, you're going to be looking at a number of different things. One is their scapular position as they're running. So you can get them, you can check their step forward, or you can check them on the treadmill, what they're doing with their scapula, if they're using one of those patterns that we talked about before of scapular depression or protraction, etc. The other thing that really commonly happens in runners is too much shoulder extension. So that as they run, they propel themselves forward by driving their humerus back into extension, and they compress the poor old biceps tendon down the front of the humerus into that bicipital groove. So if they're reporting shoulder pain as they're running, particularly on that arm swing going back, really going to have a look at that shoulder extension. And oftentimes, if you reduce their shoulder extension, and I sometimes use tape across the chest and around the shoulder to reduce their shoulder extension, or get them to focus on driving forward with the hands, almost like they're cutting through the air with more of a forward movement. So that way you're taking away the emphasis on backwards, on the extension, getting it more forward. So swimming's got a large proportion of shoulder injuries, and in swimming there's quite a number of different things that can contribute to shoulder pain in this swimming action. So we mentioned before a few things. One, decreased external rotation strength relative to internal rotation strength. A common one is limited internal rotation in the shoulders. They often get tightness through the posterior cuff or posterior deltoids as well. So check that out, and what will give you clues is that internal rotation in flexion rotation range. One of the other things is the constant end of range movement. So if the patient's swimming and they're taking themselves into end of range shoulder flexion, so if they're going into a glide through stroke where they enter the water, then push their arm out in front, when they actually rotate to bring the other arm through, it really pushes them into an overflexed shoulder position, end of range, and that's often a contributor to their shoulder pain. So you can often decrease this and take that end of range position out of them by, as they come into the water, having no glide through, but instead pulling from less of a shoulder flexion range and pulling through that way. So the third one we're going to have a look at their functional movement is boxing. And there's some common movement patterns within boxing that contribute to shoulder injuries. So one of those is the way that they punch or jab. So if they're throwing their shoulder forward a little bit, so they're getting a little bit of scapular protraction before their punch comes out, they're going to compress that biceps tendon as they're leading out. So the other thing that contributes is if they're doing loads of uppercuts or hooks into resistance, so into a bag or pads, that sort of thing. Uppercuts especially tend to load the biceps tendon, and if they're punching a heavy bag where there's lots of impact going back up the arm into the shoulder, that can often be a big contributor to injury. So one of the activity modification things that I tend to do with boxers is to take out their uppercuts for a while. So they're not allowed to do uppercuts at all if they've got a biceps tendinopathy issue, and then gradually reintroduce it as they're starting to get a bit better, but with very limited resistance. So they're not hitting a heavy bag. They might be just hitting the pads lightly with their uppercuts, and the same with their hooks. They can still do their jabs and their straights as long as they've got good scapular control and they're not doing this with their shoulders. And making sure it's speed work. Now, we know tendons often struggle with speed, and so what I often do is bring the speed back. So they might work at 75 or 80% speed, or whatever percentage you can get them to work at that doesn't aggravate their pain, and then slowly increase their speed as they get better as well. So lastly, we're going to look at weights. People that do weights will go to the gym. And some of the common things you want to assess are their bench press. So if they're getting pain during a bench press, just check how low they're going with their shoulders. And if it happens to be the bottom part of the range that they're getting their pain, then you can modify their activity so they're not coming down as far with their bench press. One of the other common contributors is their overhead press. So if they say, yeah, I get pain every time I do an overhead press, check what they're doing. Are they getting any scapular depression and gripping? It's a common pattern that's taught in gyms, is to pull those shoulders down and back and then perform your overhead press. So check they're not doing that, and maybe help to glide their scapula into up rotation and see what's happening in that. The other thing is, if they've got a biceps tendon issue, you want to take away any biceps curls down by their side. Like we mentioned before, biceps tendon wraps around that front of the humerus, and so if you can get them out of just a neutral position, up and supported on, say, a preacher bench or something out here, where they're doing gentle or lighter loading of their biceps and supported out of that shoulder extension position. That's a good thing as well. So a common limitation in your boxers, your runners and your swimmers with shoulder injuries is a lack of thoracic rotation. So it can impact your shoulders in a whole load of different ways, but you can imagine if in your runners, if you don't have enough rotation, then you've got to try and get more shoulder extension. As opposed to rotation, you don't quite need the same amount of shoulder extension. So check their rotation and check that they're actually performing rotation while they're running. Same in your swimmers, check their rotation and check that they're actually using their rotation while they're swimming, if you can get a video of them swimming. And last but not least, make sure you check their whole kinetic chain. Now we know that in a throw, for instance, 50% of the power that's generated is from your legs. Your shoulder only generates about 25% of the power. So if you've got limitations somewhere else in the kinetic chain, you're going to actually load up that shoulder. It's going to have to work harder. So check out the other areas of the body for in their functional movement, seeing if they're taking shock or they're pushing off nicely through the other parts of their body, and maybe check their control and range of movement in other parts as well. And that'll be often make the difference in getting them back to sport, is making sure that the whole body's working nicely together. So I hope you enjoyed today's session on functional movement assessment, and tomorrow we're going to wrap it up with a summary of shoulder assessment. Hey, and welcome to day 14 of this shoulder assessment video series. Well done on making it all the way through, and I hope you're feeling more confident in your shoulder assessments, in identifying what's going on with the patient and helping to diagnose them, and I hope you're enjoying treating shoulders more now. So to summarise the things that we've talked about, ideally in our subjective we want to nail down the area of their pain specifically. We want to talk about whether it's superficial or deep and the exact location. We want to find out the irritability and severity of their pain. We then want to find out the cause. So what is it within their history that's contributed to this pain? Is there a specific incident, trauma, or is it just an insidious onset? We next want to find out if there's any red flags as well, making sure that they haven't got anything else more sinister going on, and then moving into the objective. So by the time you've finished your subjective, ideally using that location, severity and history, you're starting to already come up with some differential diagnosis. Now you might start going, all right, I suspect there's a biceps tendon issue from what they've reported, or it's more likely to be slap tear from that history of trauma or whatever. But ideally, time we get to the end of subjective, we've got our history, we've got our differential diagnosis almost nailed down. So then we move on to objective examination, and we want to check their range of movement first off. So looking at identifying which movements are painful or restricted, checking their active and passive range, then moving on to palpation. So identifying, do they have any pain with palpation? And remember, there's some inconsistency with that, but trying to identify if there is any tenderness. Next thing we're going to look at is their scapula, and we want to check what's their scapular movements, active and passive like, and can we do anything about their scapular movements with manual support or manual movement of the scapula to reduce the person's pain in their functional task or their specific aggravating movements. So now we're going to use your special test to try and identify which structures around the shoulder are irritated. Now, if you get some nice positives and you can identify if it's the biceps tendon, some subacromial impingement, a slap tear, or some instability, that's fantastic. And remember, you need a combination of tests, positive findings, not just one positive finding. So if you do have that though, then great, you can tell them there's some irritation of those structures. If not, and you're looking at going, well, we've got a bit of a mixed bag, then remember those pain sciences, that the more we can take away the threat value for someone about their injuries, we can reassure them, do some activity modification, the better their recovery is going to be. So we do that reassurance, and we talk about the structures within their shoulder that might be irritated, such as their bursa and tendons, and say we're going to work on strengthening the structures around your shoulder to get more support and get better mechanics within the shoulder. And we know that there's good support for conservative treatment around the shoulder, so you're likely to have a good effect even if you aren't exactly sure which of the structures are irritated. Then we moved on to assessing the person's functional movements. So they're all going to have different functional movements or activities that are painful for them, but the more you can have a look at them in their native environment, performing that activity and modify those, the more likely you are to get some great success treating the shoulder. So what about imaging? Now, imaging around the shoulder has got some mixed results in the research. And we know that in ultrasound, 96% of asymptomatic individuals had abnormalities on ultrasound. So if you send your patient off for an ultrasound and they come up with a biceps tendinopathy or supraspinatus swelling or whatever it might be, that there's a pretty good chance, a 96% chance, that finding could be incidental. So it's not exactly ideal in identifying the structures. Doesn't really add much to your management. MRI is a little bit tricky as well because obviously we're going to pick up a lot of things within the shoulder that have issues, and we might pick up some labral tears, a little bit of rotator cuff tendinopathy, etc. But knowing exactly which one of those findings are relevant to your patient's pain, it's not always easy to identify that that's specifically responsible, and there's not a good correlation between findings on MRI and a patient's pain as well. So it leaves us in a little bit of a quandary as far as imaging goes as well. However, the times you will want to refer for an MR is if you suspect a large rotator cuff tear. So you've got those older individuals, sudden loss of range of movement and a traumatic event, and you're suspecting that they do have a rotator cuff tear, you can send them off for investigations with ultrasound or MR to identify the extent of those tears. If you have a patient that's got frozen shoulder, definitely get them off for an X-ray. Or if you suspect there's some joint involvement, so they've got a really stiff shoulder within the shoulder joint with a hard end feel, then it's worth sending them off to identify if there's anything going on within the shoulder joint as well. So after that, you're looking at potentially your younger patients with possibly a slap tear that might be looking at surgery. You can send them off for an MR to identify the extent of the tear. And anyone who isn't progressing with their conservative treatment after those around 3 to 4 sessions, you'd hope for some improvement. If they're not getting it, that's when you can start to think about getting some further investigations. So I hope you've enjoyed this video series on shoulder assessment. You're feeling more confident around the shoulder and with your assessment and findings there to tell people exactly what's going on. Now, I'd love to hear your feedback. Please send us an email, info@clinicaledge.com.au, or on Twitter at David K. Pope. So check it out, clinicaledge.com.au, and I'll look forward to seeing you again soon. So I hope you've enjoyed this video series on shoulder assessment. You're feeling more confident around the shoulder and with your assessment and findings there to tell people exactly what's going on. Now, I'd love to hear your feedback. Please send us an email, info@clinicaledge.com.au, or on Twitter at David K. Pope. So check it out, clinicaledge.com.au, and I'll look forward to seeing you again soon.